Welcome everybody to this panel discussion, which is part of the post-COVID summit, shaping the post-COVID era, as it has been named. As I commented just a couple of moments ago before we started, I think the consensus now is that there will never be a post-COVID time. This coronavirus is here to stay, but we're still in the pandemic phase, and what we're all hoping for is that we will shortly be in a post-pandemic phase. It'll probably happen at different times in different parts of the world, but that's where we're going. And I think when we're talking about speaking to this theme, shaping the post-COVID era, we're really talking about shaping the post-pandemic era. The introductory remarks in the program speak of, well, our theme is risk assessment and prevention, and it speaks of medical risk assessment. But I think we're likely to have, I'm certain actually, we're going to have this conversation on at least two levels. One is with respect to what we might strictly call medical risk assessment, that is what happens in a clinic, a medical perspective, but we're also very much going to discuss this from a population perspective, an epidemiological and public health perspective. So that's at least on which we'll be having this conversation. The question that we've been given to answer is, can we conceive and design an environment that is better suited to disease prevention? That is to say, better than we did as this pandemic spread around the world. And I'm sure that the answer to that question from all of you will be yes, but I think it's likely to be yes in interestingly different ways, having looked at your respective backgrounds. So the way I think we should have this conversation, we've got a couple of hours, so we have a generous amount of time. I suggest we do some brief introductions first of all, then I'll ask each of you to make your opening statements, maximum 10 minutes each. Then we can have a panel discussion from matters arising, and I'm sure there are going to be lots of them. I'm expecting at the same time to see on the Q&A that those who are watching online will ask some questions. So we want to allow time to address those questions, and I'll probably just pick them out of the Q&A rather than inviting people online to actually speak to them. I think that'll be more efficient. And then finally, before our 2 hours is up, I'll ask each of you to reflect very briefly on what you've seen and heard during this conversation and what your conclusions might be. So let's kick off then. And Paul is the first person on my list. So Paul, please go ahead. The floor is yours.
Thanks. Thank you very much, and very happy to be here today. My name is Paul Vandenbroucke. I'm the Chief Medical Officer of Pfizer's hospital unit, which includes all of Pfizer's anti-infectives. And so I think it's very important that we have this discussion. As we have seen, the COVID-19 has had a tremendous not only medical impact, but also economic impact. And so it's important that we are as prepared as we can be for any further pandemics. And so as a pharmaceutical company, of course, Pfizer has contributed to combating this pandemic. But we're also very much involved with anti-infectious treatment in general, and especially an important component of the fight against infectious disease and future pandemics, surveillance. So thank you.
Okay, thanks. That was brief.
I'm sorry, was I supposed to?
I mean, you could speak for longer if you can elaborate. You can elaborate if you wish.
Yes, of course. So so the COVID-19. Yes, sorry.
Sorry, we're okay. So we're dividing this into the introductory phase and then your opening presentation. Sorry. So okay. That's by way of introduction. Yeah. Thanks very much. So Andy,
thank you.
Just a few brief introductory words about yourself.
Thanks. Yes, I'm a professor at the University of Southampton, focused on spatial demography and epidemiology, and I lead the WorldPop research group, where we are focused on population mapping demographics and mobility, and often co-developing these with national statistics offices and ministries of health for health applications. So very interested to hear.
Okay, thanks. Jeffrey?
Hi, it's a pleasure to be here. My name is Jeffrey Sheaman. I'm a professor at Columbia University in the Mailman School of Public Health. I'm an infectious disease modeler for the most part. I build mathematical models and combine them with statistical inference algorithms and data from the real world to try to understand how diseases propagate, how they move through populations. A lot of the work I do is analytics, as well as projections and forecastings and counterfactual simulations, mostly at population scale. Again, pleasure to be here.
Great, thanks, Jeffrey. John, you're next on the list.
Hi, I'm John Ioannidis. A great pleasure and honor to be here. I'm a professor of medicine and of epidemiology and population health at Stanford. I also have courtesy appointments in the departments of biomedical data science and statistics. And I lead the Meta Research Innovation Center at Stanford, which is a center focused on research methods and practices and how we can optimize it. And I'm very eager to hear what people have to say and to discuss about these very interesting things.
Okay, thanks, John. Robert?
Yes, I'm Robert, as you say, or Bob Gallo. I'm professor of medicine and microbiology, immunology, and I direct the Institute of Human Virology at the University of Maryland in Baltimore. I also am the co-founder of the Global Virus Network with two other distinguished virology people. I'm a virologist and I guess blood cell biologist. It's hard to really say the rest of it. Started as an MD. I still have the degree, but it's meaningless in a sense. And I have a broad interest in viruses, more particularly less the acute viruses, although COVID dragged me screaming into it, more chronic viruses.
We might discuss as time goes on about acute and chronic with regard to COVID. Tallulah.
Okay, you got one. Yes.
Yeah.
Right. Yeah, the late disease.
Yeah. Tallulah.
Yes, hello everyone. Good morning, afternoon, evening. I'm Tallulah. I'm a public health physician and urban epidemiologist. I lead a research group at the University of Cambridge on a global diet and physical activity research group that works at the intersection of population health, urbanization, and climate change. I'm also a professor at in Innovation Africa at the University of Pretoria. So I focus largely on the ways to harness urban infrastructure development and planning for population health equity in rapidly growing cities globally. Nice to be here.
Okay, thanks, Tallulah. And last on the list for introductions, Wolfgang.
Yes, thank you very much. I'm Wolfgang Philipp. I work at for the European Commission in Brussels, and I'm the deputy head of the newly created service called the Health Emergency and Response Authority. And we are operational now since a couple of months, and I'll present a bit more about this work in my remarks later on.
Okay, so thank you all for those introductions. Clearly, we've got a wonderfully diverse set of interests and expertise among the panel. So we'll kick off then with the short presentations from each of you. 5 to 10 minutes, 10 minutes max, please. So let's do that in the same order. So Paul, back to you.
Yes, great. Thank you very much. And of course, the COVID-19 crisis has really reinforced the need to act to help prevent and prepare for future health crises. And in that surveillance, continuous systematic collection, analysis, and interpretation of health data has really played a vital role in managing COVID-19. And to predict and manage future potential threats, we must really have robust global surveillance capabilities, and they should leverage the collective expertise and resources offered by industry, but also governments and healthcare systems alike. So we're really proud of our leadership in surveillance. If you consider antimicrobial resistance, one of the biggest threats to global public health today, for instance, in 2017, we launched the Atlas platform, which is now one of the largest antibiotic and antifungal surveillance platforms in the world. And the Atlas surveillance program has a very large geographical reach. We have data from 78 countries, including countries with less specialized health networks. And this has been recognized by the Access to Medicine Foundation for being the only company that publicly shares raw data from our AMR surveillance program. So through improved access to surveillance data, the Atlas database ensures key decision makers have near real-time access to resistance trends. And this gives them a critical tool to better adapt antibiotic stewardship programs to help combat the spread of resistance pathogens. So we've seen that infectious disease knows no borders. It's therefore critical that we also help strengthen the ability of countries with less specialized health infrastructure to be able to employ surveillance measures also. So we created a partnership with the Wellcome Trust around a multi-year public-private research collaboration with the governments of Ghana, Kenya, Malawi, and Uganda. And that partnership helps to address a gap in their health systems by establishing a platform to track resistance patterns and to better understand the burden of antimicrobial resistance in that part of the world. So really keen to identify even more collaborators who share our aspirations and with whom we can share our considerable resources to partner for the greatest impact. We really know that there are even more possibilities to improve global pandemic preparedness, especially with the wealth of data that is available to us all. So to improve preparedness, we really need to share information about emerging pathogens more efficiently. This includes not only information about the pathogen itself, but also genomic sequence information and so on. So really, and it's very important, as we've seen during COVID-19, during the COVID-19 pandemic, it's really important to avoid delays in sharing this information. It's really essential to ensure effective medical countermeasures can be developed quickly. So widespread public health surveillance is also necessary. We must know which variants are most prevalent to be able to provide countermeasures that will provide the greatest level of protection. And we could imagine, for instance, an algorithm that leverages big data analytics to process electronic health records and sample testing data collected by governments, health systems, and the private sector. And to improve access to this data, we could really glean insights to inform the appropriate use of medicines and also, of course, to track resistance to them. Through this multifaceted approach, collaborating with industry, governments, and healthcare systems, we can really make progress to help minimize the threat posed by future outbreaks of infectious disease. Thank you.
Okay.
Thanks, Paul. That was fascinating introduction. I think quite a lot of people listening will be surprised by a number of things you've said. Your interest in your company's interest in surveillance for one thing, but there are two or three things that I think we'll come back to in the conversation. One is the partnership between public and private sector, industry and government. Another is the sharing of data that many of us in public health have long been advocating, but in a commercially sensitive environment, there are difficulties there. And also your emphasis on antibiotic resistance, which has had its highlights, but it's also had its lowlights as well. It's quite difficult to keep it in the public eye. So we might come back to all of those things. Anyhow, thanks for that.
With pleasure. Thank you.
Christopher, it's hard to hear you.
Yep.
This is Robert.
Can you hear me?
Can
you hear me now?
Yes.
Is that better?
Much better.
Okay, I'm turning my volume up as well. Sorry, my microphone was a little lower. Okay, thanks Bob for pointing that out. Andrew, you're next.
Sure, thank you. I'm going to share some slides, and I think this follows on quite nicely in the discussion about data. And I think we've we've been, throughout the pandemic, all of us kind of overwhelmed with data on graphs, whether it's cases per 100,000, whether it's those cases broken down by age groups, hospitalization rates per 100,000, or share of the population vaccinated. And as we've just heard, surveillance is a vital part of our reaction to COVID, to infectious diseases in general, whether it's tracking health and the burden of disease metrics, detecting, reporting, and investigating, and the timely and complete reports. What I'm going to focus on is perhaps while the others in the group here may focus more on the numerator, the data that we collect on COVID and other diseases. I'm focusing here on more about the denominator, so the population data, the communities that data comes from. So whether that's census registries, administrative records, or household surveys. And the importance here is to provide that denominator. So if we see hundreds of cases in a health facility, is that a major outbreak? It's hard to know without having some kind of denominator to provide context. There's 100 cases out of millions of people. It's not such a major outbreak as if it's 100 cases out of 1,000 people. So what is our denominator? And who are those people coming in? If we see a large number of elderly people, but that health facility serves an area that has a large number of elderly people, then it's maybe not such a risk factor that we're defining. And in terms of how much vaccine, the actual delivery and response, how much vaccine is needed, where should it be delivered if we're actively delivering that vaccine, and how to deliver it in terms of designing campaigns. And then thinking about population movements as well. What is the risk of importation and spread? So all of this comes back to something about those populations and how they move around. The problem is we often have some data gaps that are pretty core in terms of those demographic data. Here's a map of the most, from 2020, the year of the most recent census. And we see here this vast area of green, meaning pretty much in 2020, most countries haven't had a census in 10 years. There's only a handful of those that actually had a recent census. So we were relying a lot on projections for those denominator numbers. If there are some extreme examples, countries like DR Congo, the size of Western Europe, last census 1984, and you can talk to one ministry and they're using 100 million as their total population. Another ministry is using 60 million. 1979 for Afghanistan, a lot has gone on there. And even a country in the news at the moment, the last census 2001, so hard to even get baseline numbers. And of course, there are now probably about half the countries that had planned to do a census has now been delayed, budgets have been cut, or have actually been cancelled. So we're seeing a major problem in terms of basic demographic data. And even if we can do a reliable census, some of the challenges we face are varying fertility rates, migration patterns, and displacement. And of course, in many statistical settings and the health settings, we have birth registration, we have death registration, we have administrative records, which can help us update those numbers in the absence of a census. But in many parts of the world, those data systems are pretty weak, particularly across sub-Saharan Africa. We can see in some cases less than 10% of deaths actually being captured. So there are new forms of data that can help us. It's not all bad. We look to satellite imagery and the machine learning that can now identify buildings rapidly. It can identify the types of those buildings, non-residential. And some of the digital forms of data that are coming from the records of flights, of movements of people internationally, but also in terms of the movement of mobile phones and the devices we carry, giving information here, looking at the movements of people in and out of Wuhan from Baidu, the Chinese equivalent of Facebook. So we have these devices, and we also have methods that this is some of the work that we do in the University of Southampton in the WorldPop group is co-development with statistics offices and ministries of health of cheap and effective ways of collecting small area population data to combine it with these new forms of data and produce estimates of populations and their characteristics to fill some of those gaps. It's exploring new forms of data from those movement of phones that can feed into models that give us equivalent results to a census where those cannot be done because of expense, because of logistics. But these are not perfect. But we do see these starting to feed into health information systems, these kinds of data sets, and being used for health delivery, for working out estimating catchments, for designing microplans for delivery of interventions. So just the key message I wanted to get across, I think, as we've heard already in the first talk, I think COVID has highlighted the value of strong surveillance systems and being able to respond rapidly and effectively to mitigate disease impacts. It's also highlighted our global connectedness, that things spread very fast between countries. And of course, it's also highlighted the data gaps and inequalities that exist across the world. Some of these new forms of data from satellites, mobile devices do offer opportunities to fill gaps when integrated with appropriate statistical models, with demographic data, but we will face challenges in predicting and halting disease spread without investment in some of these basic data to support surveillance. So access to timely, reliable population data ideally should be a goal if we're going to ensure appropriate, effective, and efficient responses when the next outbreak or pandemic arises. Thank you. I'll stop there.
Thanks. Thanks very much, Andy. Just by the way, when each of you is not speaking, could you just mute yourselves, because there's a little bit of background noise as well. I think Bob, perhaps coming from your microphone. Andy, like the first talk, there were lots of interesting things in there that I think some of which we'll come back to. Of course, epidemiologists love denominators, but one of the things we've learned during the COVID pandemic is that action is based on public perception, and public perceptions are often not particularly well tied to epidemiological statistics. Another thing we've learned, I think, is that in some instances we have a deficit of the data we really need and an excess of data that we don't really need, but people use it anyway. So I'm thinking about flight connections around the world, which is one of the first things that people reach for, which doesn't necessarily answer the questions we want to ask. But very thought-provoking. Thanks very much. Let's go to the next one. Jeffrey, over to you.
Thank you. I'm going to share my screen and some slides as well. Just take me a moment. If my computer responds, there we go. Can you see that, Chris? All right, so I'm going to be reiterating and expanding on some of the comments that the previous two speakers spoke about. And I've just got a very brief list here of some steps that we could take towards better pandemic preparedness at population scales. One of them, the first one, which is the one I'll focus on, is really my own focus, and that is population scale modeling, analytics, and forecasting. And I'm going to advocate that this should become better integrated into public health response to infectious disease threats, and that there's a lot of work that could be done in the peacetime to better stand up these kinds of capacities and make sure that they are embedded with the data collection, archiving, and sharing, which also needs to be improved, as Andy and Paul both alluded to, and also coupled with improved communication protocols with emphasis on evidence, simply because we've had a lot of disinformation and misinformation throughout the pandemic that clearly indicates how much we do need to work to improve our communication strategies and understand that it's not going to always be ideal for reasons of both misinformation and disinformation. So I am going to focus on infectious disease models. And what does an infectious disease model do? Well, typically it provides limited context-specific information. Infectious disease models have, in my mind, three principal uses. They're for simulation and inference, where you try to simulate what has actually happened and to infer some of the characteristics and properties of the system that are not observed. So we've heard certainly throughout this pandemic about the basic reproductive number, the time-varying reproductive number, the latency period. All these are characteristics that are inferred either statistically or mathematically to try to understand what makes this virus tick, how its properties are distinct from other viruses or pathogens that we've looked at, and whether or not we need to actually invest in control with certain levels of expediency, let's say. The second thing that we can do with them is certainly forecast future outcomes. Sometimes this devolves to projection, and I would argue that for COVID, we really have been looking at projection and not forecast, but we would like to have some insight into what the incidence, the burden, the hospitalizations, and the rate of mortality will be in the coming weeks and months, and that's what forecast and projection can do. And the third is counterfactual simulation. If you have a well-specified model that is informed by data and constrained to represent what is actually going on, you can actually start to play around with it. And you can say, well, what would happen if we were to impose this control instead? Mathematical models provide you an in silico environment for actually doing the things that you cannot do in the real world. You don't get do-overs, you don't get the chance to do things twice. This allows you to explore control opportunities, obviously in an idealized setting, but in a way that can't be done in the real world. So to just give you some examples, here's an example of simulation and inference. This is for the United States. It shows national cases and deaths on the top row. In the middle, it shows the New York City metropolitan area, cases and deaths. And what you can see is that we were able with this model, through a combination of coupling a mathematical model with Bayesian inference algorithms and data observations of cases and deaths, simulate what had gone on throughout the United States. These are just two such examples, the aggregations for the New York metro area and the US nationally. But at the same time, because we were doing it, we were able to estimate the time varying reproductive number. That's shown on the lower left, and it's shown for 6 metropolitan areas. And we can see how control measures were resulting in, and this is the first spring wave of 2020, so there were lockdowns, there were school shuttings, there was shutdown of mass gatherings, etc., resulted in a drop of that reproduction number over time. So this is an example of this idea of simulation and inference. Here's just a projection of a shot of what it would look like if you made a forecast. This is an actual real-time forecast my group generated back in 2012 for Salt Lake City, Utah in the United States. The black observations in the left plot are observations that we had in hand of influenza-like illness multiplied by virological positivity rates. It's called ILI+. The red X's or dots are observations that we did not have in hand at the time. The magenta line shows the mean trajectory from a fitting of this model to the black observations and then how it forecasts outcomes in the future. And the individual lines, green for what's in the past and gray for what is in the future, indicate the actual ensemble of forecast trajectories that form that mean magenta line. And you can see how they capture basically the area under the curve, the duration of the outbreak, the timing of the outbreak, and a number of other features that may be of use for public health officials as well as clinical practitioners. And then there's also counterfactual simulation, and this is a shot of what we did in China in early 2020, showing that in the absence of undocumented cases, that you would have seen an 80% decrease roughly in an absence of undocumented infections being contagious, you would have seen an enormous reduction in the number of confirmed cases. And what this actually points to is something that I'm going to get into in just 1 minute with a few more minutes of my time. What I would advocate for this preparedness for modeling is something that in the US we're standing up the CDC. In the UK, they had this well in place, I would argue, comparatively to many countries during the pandemic, though I understand some of the funding is going away for that now. And I think it's something that actually needs to be stood up. So the CDC in the United States has established a Center for Forecasting and Outbreak Analytics. And this is an idea that's been kicking around for about a decade. And the pandemic finally gave the motivation and the impetus to put it in place. And the idea is something like a National Weather Service, where you have operational analytics, forecasting, and modeling of infectious diseases put in place. And you have a centralized authority that people can turn to. It doesn't mean the authority won't make mistakes. It won't mean you won't have bad forecasts. There won't be mess ups, of course, but you have a group of people who are there to actually focus on this kind of operational activity, such that when there is the next pandemic, when there is the next crisis, you have a group of people who have been invested and are funded to actually carry out this kind of work on a professional level. So what is one example of how this might actually work? I'm going to use it from my own work here. We had done something called the Virome of Manhattan analysis. We were looking at all common respiratory viruses in the borough of Manhattan within New York City. And what you see in the first column here was documentation of the number of infectious episodes in a cohort of roughly 200 people that we followed for 19 months in New York City. They gave us daily symptoms and whether they had sought medical care because of those symptoms over their phone, went into electronic database, took all of 30 seconds on a daily basis, and there was great compliance. And then once a week, regardless of how they felt, we swabbed them and tested them for 18 common respiratory viruses. And what you see there are episodes defined as 1 or more consecutive weeks with the same virus being shed. And these are just grouped into groups. We had different subtypes of flu, we had different types of serotypes of RSV, et cetera, but I've aggregated them all. And you can see the number of episodes there. So for human rhinovirus, they're 275. For the endemic coronaviruses like OC43, 137, they're 32 for flu. The next column says MA, that stands for medical attention. This shows you the number that sought medical attention during those infectious episodes because of the severity of their symptoms. The next column, probability of seeking medical attention, given that you have that infection, shows you the fraction of those episodes for which somebody actually sought medical care. And you can see the numbers are low. They range from 4% to less than 25%, even for flu. And what it indicated to us was that pre-pandemic, this is 2016 through 2018, that when people got one of these common respiratory viruses, most of the time, they did not seek medical care. As a matter of fact, most of the time, their symptoms were mild. And what that indicated to us was that they do what you or I used to do when we got a sniffle or a little sore throat, which was absolutely nothing. We'd still go to work, we'd still send the kids to school, we'd still go shopping. If we have a business trip or a vacation, you still get on a plane. And what do? We take the virus around with us, and we're detectably shedding it and probably contagious at some point during that time span. What makes these viruses common is the fact that people don't do much about them and that most infections are not documented. If people don't go to a clinical care facility, they're not going to be documented. So the bottom line was that we saw the epicenter Wuhan in January 2022 and the cases exploding outward from it, going to throughout China and then hopping on airplanes and going to Thailand and South Korea and Japan and the US and then making it around the world. And in that very early stage, we said, this virus is acting like a common respiratory virus. Most of the people who have it are not aware they're contagious. They're either shedding pre-symptomatically or asymptomatically, or maybe paucisymptomatically with mild symptoms. And the consequence of that is that if this thing is like a common respiratory virus, it's not going to be contained. It has an epidemiological property that's not going to allow it to be controlled because it's that property that allows those common viruses to be common. So we built a mathematical model. I'm not going to go into the huge details of it. We coupled it with inference methods and observations. We looked at the period before lockdown, and we said we want to estimate what fraction of infections are cases and what fractions are undocumented, and are those undocumented infections contagious? And what we did is, in our first cut for January prior to the lockdown in China, we estimated that 86% of infections were undocumented, 6 and 7, and that per person an undocumented infection was roughly half as contagious as a documented infection. We could then simulate the actual outbreak using that. We could do that counterfactual simulation I showed you momentarily, and it led us to conclude from this analytic exercise with modeling that unlike SARS-1, there were many undocumented SARS-2 infections, including paucisymptomatic and asymptomatic, and they were the majority of the infections, and that they were responsible for the majority of transmission. And we even saw evidence of pre-symptomatic shedding and the contagiousness among confirmed cases, and that this virus did indeed have epidemiological characteristics consistent with a common respiratory virus and was therefore not likely to be contained. So I'll stop there. That's one little more detailed example of how analytics may be put in place, but I do think modeling has a large place at the table, and it's something that we need to invest in to be better prepared for future pandemics. Thank you.
Thanks very much, Jeff. That stimulated a number of thoughts of mine, and I guess among others as well. One was that modeling has been surprisingly prominent during this epidemic. If you put modeling alongside all other forms of scientific investigation during COVID, it's had a pretty good run, actually, and we might want to discuss a bit later whether it has survived well. But in my sense, for example, behavioral studies were much less prominent, particularly at the start of the epidemic, although they became more so a little bit later on. Of course, perhaps the big question from your presentation is, if you have asymptomatic or poorly symptomatic infection, then how does that influence the approach to prevention and indeed risk assessment, which is our main theme. Anyway, thanks. Really very stimulating presentation. Let's go to John, please.
Thank you, Chris. Let me see if I can share my screen. I hope it's visible now.
Yep.
Okay. So the previous presentations were very insightful, and I will try to build on some of the themes that were mentioned, especially around the questions of can we really predict and can we really stop pandemics or new waves at an early stage or manage them efficiently? Can we be preemptive also in terms of prevention? Chris mentioned that. So maybe to avoid a lot of deaths and a lot of impact on society and on our world at large. Jeff mentioned models, and models have had a very prominent role in pandemic understanding and planning. I think that they were valiant efforts and we learned a lot from them. Unfortunately, we realized that it's extremely difficult to predict viral spread and impact, especially at the beginning. If we have a new virus or a new pandemic, we're starting pretty much from point zero. Even if we know a bit more, now we know far more. So if we have new waves from the same virus or variants, probably we might be a bit more prepared. But we have to meet some of the challenges that are inherent in forecasting. And I have tried to summarize these challenges and some potential solutions in this paper, which is pretty long, but I will just highlight some main issues. One main issue that Andrew and Jeff already mentioned is data. We lack good data, especially at the beginning of the crisis. We have very, very poor data. And some of our models probably don't need data, but they still need to make a lot of assumptions. And obviously, in the dark, we can make a lot of errors in assumptions. And we have to be very careful to try to accommodate the right amount of uncertainty around each one of the assumptions. Many of the estimates have very high sensitivity. So this may be something that's inherently impossible to fix, and we should only acknowledge, especially in early stages and in new surprises that may emerge, so that we can take that into account in decision making. I have seen a problem with lack of incorporation of epidemiological features in many of the models that became very popular. For example, most of them did not take into account the very steep risk gradient that we saw for risk of severe outcomes. And another challenge has been how to incorporate past evidence. For example, we had a similar large-scale pandemic that was a mega pandemic in 1918, but obviously the data from 1918 were of very poor quality, of course non-randomized, and even the observational data were very uncertain. Recently, we looked at 1,400 mathematical models in infectious diseases, and we found that only 1 out of 7 shared their code and their data. And even that 1 out of 7, if you tried to get them to work in your own environment, probably many of them would not work. So we need more transparency. Errors are very common. There's errors in my work all the time. I'm very happy when I find out that I have made some errors. Some others are very difficult to find out unless you have other eyes looking at them, and transparency is very important. Lack of determinacy, looking at only one or a few dimensions of the problem at hand. It's not just the virus, it's many other problems that are caused by the pandemic. We need to try to take all of those into account as well as we can. Lack of expertise in crucial disciplines, especially when we have these multi-dimensional problems and society, economy, health is affected in multiple dimensions. Groupthink and bandwagon effects, if sometimes we're stuck in some estimates or estimates or estimators, and it's very difficult to move on. And selective reporting. Here's one example that I think was very catalytic in the early days. One of the best teams in the world, Imperial College, published their work in Nature, showing that in their hands, with their model, draconian lockdown was what saved millions of lives in the first wave, as opposed to other more targeted measures like self-isolation or banning big events. And we looked at their data. We also looked at another model that they had produced at the very same time. And that other model had a much better fit to the data. And it actually showed that draconian lockdown did not have a benefit as opposed to the more focused measures. How do we find out eventually which of the measures are the best? I have argued from the very early days of the pandemic that we need randomized trials. I think that models and observational data are very useful, but I was very happy that we had two randomized trials on masks. One might argue that they don't give the same results. I would argue they give pretty similar results. They both show that we have a reduction of about 10%. One is significant, the other is not, but that doesn't really matter. It's a reduction of about 10%. I think we can use more randomized trials to inform us about different interventions. There's about 30 of them that have happened for social distancing interventions to date, which is far, far less compared to the 4,000 that we have launched on drugs and biologics and other medical interventions on the pandemic. Better integrating clinical epidemiology and risk stratification, I think, can really make a difference. It's not going to be the same in the next pandemic. It may not be the same even with a new variant of this virus, but at least for what we saw, we had a very strong risk gradient. We could see very quickly, and we could map the risk for the average population, but also the risk in single individuals according to their age and according to their comorbidities. We had an amazingly steep age gradient of about 10,000 fold difference in risk. Having worked in precision health and precision medicine, I'm very happy to find risk ratios of 1.3. So seeing a risk ratio of 10,000 is really astonishing. We need to consider, as I said, all the dimensions of health, society, and economy. Lots of things can go wrong as we try to respond and meet the challenge of a crisis. We have to take care of our health care at the level of prevention, secondary care, tertiary care. We need to think of how preventive services are affected, of what happens to mental health. We have devastation of mental health, unfortunately. We have to think long-term about what would happen to other diseases, what would happen in different places, different countries, different locations may need a different touch in terms of how we handle things. Maybe they cannot tolerate some interventions and maybe other interventions might be more feasible. And finally, I think that we need a prevention-focused orientation. And I'll give one example here, smoking. About 10 million deaths will be happening from smoking every year in the next century. I hope we survive a century. With climate change and with war, I'm not even sure about that for humanity. But if we do, and we do nothing about smoking, we estimate that about 1 billion people will die in the next century. Half of them will be less than 70 years old. 67% chance of dying from smoking for a smoker. Half of COVID-19 deaths may be due to underlying diseases due to smoking. The tobacco industry is thriving. It's a 1 trillion behemoth growing at 2% per year. And it has made a reputational push actually during the pandemic. It's growing its business. It donated ventilators to some countries to show that it has social responsibility, which is obviously ridiculous. I have argued along with the Prab Hadza that maybe now it's an opportunity to eliminate the tobacco industry. And maybe then this horrible pandemic might be a covert blessing, helping us to save up to 1 billion deaths over the next century. So a prevention environment would take into account all of these factors. And this is what I want to close with. The pandemic hit mostly the poor and the disadvantaged. And many of the measures that we took really did not help them much, actually made things worse for them. So we need to work around social injustice, inequalities, racism, and poverty. All of these are major themes. We don't need to wait for the next pandemic for that. We need to work on them right now. I mentioned smoking, but there's also other modifiable risk factors in lifestyle. For example, obesity is a major risk factor for adverse outcomes with SARS-CoV-2. Poor care in long-term care facilities, it's a chronic problem. It hit us now, but it has been there for a long time. And we saw in the first wave about 50% of the deaths in high-income countries being in long-term care facilities, a bit less subsequently, but these places were devastated. Poor adoption of effective public health measures. Again, we don't need to wait for a pandemic to hit. Harmful, pro-contagion, aggressive public health measures, for example, blind lockdowns. I think we need to avoid them and try to isolate which of the elements of these strategies have worked and which of them have been detrimental. Ineffective vaccination strategies, we tried, but I think that in many places we did not get the uptake that we wanted. So we need to go back and ask what did we do wrong and how can we get things better? And finally, how do we maintain trust in public health? I think this is very important. We're going through a crisis. Lots of people get very sick or get very scared, and they see a chaotic environment. So we need to think of the big picture and of all dimensions of health, society, and economy. Use the best science, don't cut corners in science, and knowledge uncertainty, obtain randomized evidence, employ restratification, avoid divisiveness, oppression, aggression, maintain and augment trust in public health in both the short term and long term, and avoid fostering inequalities and marginalizing segments of the society. In fact, we need to try to get all these people back to society and decrease inequalities. Thank you very much.
Thanks very much, John. Like the others, many big issues that we will surely come back to. Prevention's one that's close to my heart, as I wrote a book on it recently. But your point about smoking is a big point too. The problem, a problem with smoking is that, like other chronic diseases, it will never be labeled a public health emergency in the same way as COVID or Ebola or Zika are under the international health regulations, and that's partly a matter of public perception too. So thanks very much for that, John. Let's go to the next one, Robert.
Thank you. Yes, thank you very much. John moved things a little more upstream, and I'd like to go kind of all the way to the extreme. So this talk will be that way, and will be attempt to be a little more provocative as well. I first wanted to start by saying that what I see is that people don't remember lessons of past pandemics or serious epidemic diseases, at least in the few that I've seen and been familiar with or reading history. For example, Oshansky, a historian of polio, begins his book pointing out that the lessons of the great flu pandemic were lost, and people forgot those lessons. And as I viewed it, I started thinking of this as about a generation to a generation and a half we forget. So I don't believe announcers when they say we will never forget, when they talked about COVID from the beginning to now. If it would end it tomorrow completely, my guess would be in a generation and a half, we would forget about it. Looking closer, I can tell you, I spent the first 30 years of my career at the National Institutes of Health in Bethesda and at the National Cancer Institute. And in that period of time, when I first came, it was the 1960s, late, and there was a really healthy respect for infectious disease and the memories of polio, for example. There was never any talk that belittled it, but I can promise you by the mid-1970s that was over. And a lot of evidence for that, including the closing of departments of microbiology in the United States at some famous medical schools. And I certainly can tell you, I remember vividly, very important, these are laboratory scientists I speak of. It's a little bit different world from, obviously, maybe a major different world than the public health people that are in the panel and that are involved in this now. But from very, I would say, scientifically powerful individuals, there was a cry to put all funding away from infectious disease. It was, quote, a problem for those in tropical disease institutes and centers, and the rest of the money really should go into chronic degenerative diseases. Ironically, some of those that they were talking about were actually caused by viruses. But there was this push against that in the funding to be elsewhere. That was roughly about 30 years after the last big epidemic in the United States of polio, and even memories of epidemics of influenza that were quite serious. So with that, in the back of my mind, I felt we had to do something to make sure that knowledge is maintained, that knowledge is, we keep abreast with it. So for me, and I don't want to, this is not a debate as to what's more important. Remember, my world is more of a laboratory scientist, even though I carry the MD degree. So for me, the key needs post-pandemic, as well as in the current pandemic, were medical science knowledge. That is really upstream. Maintaining and keeping pace with future developments in medical science knowledge. A sufficient number in the global presence of virologists. You may stop and think about that and say, when the AIDS epidemic came, when we were going through it, it was a time we were evaluating this, and there was in fact a decline in virologists. And then they thought, how do we get into virology? It's all chance. You happened to hear a lecture, you decide to go into it. It stimulated you, or you knew somebody. For me, it was playing tennis with a Chinese friend who was a virologist, who convinced me that my interest in leukemias of humans would be served by understanding how viruses cause leukemia in animals. And I began searching for human viruses of this kind, now known as retroviruses, of which HIV is one. And we found a leukemia virus causes an unusual leukemia, a T-cell leukemia, on the way to HIV. I felt that we needed expertise with every single kind of pathogenic viruses, not just the training of a number of virologists. And we set about thinking of ideas for that. And we needed global cooperation that had to fit in the scheme. So I co-founded the Global Virus Network, or GVN, about 10 years ago, but the first years were really nothing. I did this with the late Reinhard Kurth, who was director of the Paul Ehrlich Institute and then director of the, in Berlin, of the Robert Koch Institute, and then prematurely died of cancer, prostate cancer. Along with Billy Hall, head of the Infectious Disease Institute in Ireland. And we found almost instant cooperation and the feeling that this was long overdue. We wanted the Global Virus Network to accomplish a number of things. All 5 needs that I just mentioned to, but it's not an inclusive list. Well, this has been addressed by the other panelists already. It doesn't include really the need for improved public health regionally, locally, internationally. But the other 5 needs I had at that slide, the previous slide, are all already being met to some degree, not as much as we'd like, by the Global Virus Network or the GVN. I looked at the role of government, and I think government overplayed their hand in this pandemic, and generally does. I don't think the government should be our key leaders in science. You heard the discussion that you have symptomatic transmission, asymptomatic transmission, or transmission in the earliest days. In the United States, there was a position by the government from medical scientists that viruses didn't transmit asymptomatically, which was silly. Also, there was a resistance of aerosol transmission claimed by Chinese scientists. We were talking with Chinese scientists in the Global Virus Network before information was coming to our own government, before information was flowing rather freely, back in the early December period of 2019. So we wanted to be sure that this global network included everyone, even people we have a somewhat, what's the right word? Well, we're not happy with, that's for sure, some governments at the moment. We didn't exclude anyone from being part of the GVN. So no, all the major nations just about are included. The role of government in my mind should be for funding, for oversight, final decisions. But they sure shouldn't be primary in sciences. Why? Because which government do you want to follow? Let's review that when you think about, I won't go through it, just in your own minds. What happened in the pandemic we have experienced and are still experiencing? I mean, one government differed from another in which tactic it was taking, and sometimes still do. And none have the breadth of needed expertise, nor needed trust or cooperation from many nations. Why should we be so very limited to who the government selects from the government to be talking to us? I remember at the start when we were having problems with diagnostics, that one part of our government in the United States was blaming another part. They were blaming CDC for not having the blood test, that it was CDC's responsibility. But my coworkers and I were working at NIH when we made the HIV blood test. It wasn't CDC. It was a problem of failure by all of us, including my own institute. We didn't pay attention to it, thinking an acute viral disease would be simple to have a blood test for. Turned out not to be so simple, and people were avoiding it and not doing what we should have done at the onset. So we had a late, poor, undeveloped response to diagnostics. And I would also say that a private organization like the Global Virus Network, and I don't mean it should be alone, it should be more than the Global Virus Network. We have important interactions with industry now, and we're very happy with the one with Pfizer that's been developed in the last year and a half or so. So I think organizations like the Global Virus Network should be in a far more central position, working with academic institutions and other private organizations, and somehow linked to help the WHO. So what is the Global Virus Network in a little more detail, and then I'll come to the finishing point. The way I already said, it was founded about 10 years ago. There are now 69 virus research centers of excellence in 37 countries. There's also 12 affiliates working to become a center of excellence. We have training programs for young virologists, especially for developing nations, both in Florida and in Baltimore. We have regional centers that really cover the globe now, that act administratively as the leaders in those centers. We cover expertise with every single known pathogenic type of human virus and many animal viruses. We have strong collaborations with task forces related to key local or global threats. We're not under any government, so there's no exclusion by politics. It hurts financially, but we feel it's essential. Its objectives are advisory, advocacy, we're talking about the importance of virology and vaccines, etc. The training of new virologists for the future, to be certain that we don't have deficits like we've had, and in a sense still do have. And science response as needed, and as we are financially capable of. I want to turn my attention to an example of a new approach which has come out of the Global Virus Network in a collective manner with strong collaborations, and it's the stimulation of innate immunity by using repurposed, old, safe, inexpensive, available vaccines like OPV, like MMR, like shingles, etc. They are proven of broad, temporary, but rapid, like in an hour or two. Let's say you have a new epidemic occurring and you had a great number of visitors going to that region. Let's say a new epidemic in Egypt, respiratory, particularly where these things can be effective. You don't know the cause, you don't have a vaccine. A non-specific, live, safe, inexpensive old vaccine works. It works well in many respiratory viral diseases. The information is now, I think, very, very strong. And without harmful effects, and even good, combined with specific vaccines. They augment adaptive immunity, of course, that's what happens. Innate immunity comes first. I think they should be available, ready, and used immediately in any new epidemic or pandemic until we have specific vaccines. And even then, when the specific vaccine has problems with variants or problems with duration, they should be thought of to help because it will augment the specific vaccines. These are the points I wanted to make for discussion, and I hope I didn't go over time.
Thanks, Bob. Super, really, really provocative as well. Among all of the questions you've raised there, one of the really big ones that confronts me often as a former WHO person is how should WHO now attempt to reconfigure the global public health architecture, all of these different organizations that do different things and have different strengths. I think that's one of the gigantic intellectual challenges that faces WHO at the moment, and I don't know what I don't work there anymore, so I don't know what their proposed answer is, but I think you've through your discussion of GVN, you've provoked that question among others. So thanks very much for that. So we have two more presentations before we get to the end of the first round. The next one is Tallulah. Just before you start, Tallulah, can I just encourage those people who are listening but not among the panel of speakers, just if you do have questions, just pose them in the Q&A. I see that some are starting to appear there, and we'll get to those in due course, but this is just to encourage others to do the same. So Tallulah, please.
Thank you, Chris. So it's been really interesting listening so far. I'm going to take us back upstream in a slightly different direction, focus particularly on the unit of cities. and answering the question of the session around how to design a physical environment that's better suited to disease prevention. But before I did, I thought it was interesting, and Chris, you alluded to this at the start, one of the overarching questions was around how can policymakers, businesses, and citizens proactively prepare for a post-crisis world. And I would actually challenge that overarching question that we should be preparing for protracted crisis future, because the broader context outside of the pandemic that we're facing in terms of the climate realities is one of increasing uncertainty. And so we should be thinking about how we deal with uncertainty and how we deal with acute, not just acute, but chronic crises, and how we actually not just deal, but thrive in those spaces. Because I think some of the challenges of how we respond at the moment is just trying to get back to normal, quote unquote, in the context of an ongoing crisis. And I think that's partly because the terminology that we use. So, the second point was that I actually asked for this the title of this session to be changed from thinking about intervention in healthcare to health. Again, because even though I'm a physician, a public health physician, I say I work in health outside of healthcare. You know, we talk about how the majority of factors that influence health lies out of healthcare, but when we talk about addressing health, we in the kind of broad context focus on healthcare. So a lot of what I will talk about is addresses those broader majority determinants. So I will be touching on 4 key points in the context of thinking about managing uncertainty emerging from complex adaptive challenges whilst preventing the preventable. And that's really key. The first would be around surveillance. The second is around equity. The third is around the need to rethink resilience. And the fourth is thinking about integrated action, integrated governance. And I'll touch on these hopefully quickly. The first, thinking about surveillance, and I think the first speaker touched on aspects of surveillance very thoroughly with respect to the pathogen. I just want to bring everyone back to the what in epidemiology we call the epidemiological triad of the agent, the host, and the environment. So when we're talking about transmission of any disease, it's not just the agent. The agent has to have a susceptible host, and it has to happen in a conducive environment. And what we see often when we talk about surveillance is that the different components of those data actually end up being siloed. So we have surveillance of the agent, and we have a sense of, you know, as has been spoken about earlier, but we know little about the distribution of susceptible hosts. We don't know enough about the environments, and critically, that surveillance doesn't happen altogether. So I just want to highlight the first point in thinking about designing an environment for disease prevention is that we actually have to bring those surveillance components together. For example, how do we understand the distribution of exposure to conditions that increase vulnerability? How do we understand the distribution of comorbidities in relation to what we're seeing in terms of the surveillance of the agent? So that's the first thing on surveillance. The second is equity. And I want to essentially highlight 4 dimensions of equity here. So equity with respect to exposure, equity with respect to vulnerability, equity with respect to access to care and access to information, and fourthly, equity with respect to consequences of illness or consequences of action. And across those different dimensions of equity, what we've seen play out in the pandemic is that the inequities at pretty much every context. So I'm in London at the moment. So we see the equities in terms of who very early on in the pandemic was exposed, whether that is to do with occupational conditions and social safety nets, whether that was respect to inadequate housing and ventilation and overcrowded housing. So really highlighting that inequity has been really critical. The second, and that was alluded to earlier, is vulnerability, something like obesity. So globally at the end of 2020, there was some data from that the World Obesity Federation released that showed an ecological study, but that COVID mortality rates were more than 10 times higher in countries where overweight prevalence exceeded 50% of adults compared to countries lower. Obviously, that's an ecological study, but it really highlights the importance of really considering the vulnerabilities, and critically, when we think about prevention, of tackling those vulnerabilities as a critical part of emergency preparedness. The third is dimension of equity, pertains to equity, access to care. That was alluded to already in terms of who has access to care, but I want to highlight access to information because critical to preparedness and disease prevention is access to reliable information and tackling of misinformation or disinformation. And so really critical that we consider that dimension. And the last point dimension of equity is in terms with respect to consequence. So what happens if you get ill? It's okay for me. I got ill, as we do. I worked from home, and there was very little consequence either to my health, thankfully, or actually to my livelihood. Very different from others who may have that may lose their jobs as a result. And similarly, when we're thinking about public health actions, how do we ensure that we're taking into consideration what the consequence of those public health actions are? So I've spoken about surveillance and equity. The third point I wanted to mention was the need to rethink resilience. So I'm surprised that it hasn't come up yet, because normally when we talk about disease prevention, we talk about preparedness, resilience comes up, and I have a love-loathe relationship with that word, because it's often used in a very reactive way. So how do we, in the context of an emergency, how do we see is that many of the shocks and stressors that drive both acute and protracted health emergencies arise out of intentional choices by actors across sectors, from the local to the global. And I think it's really important that we internalize that. So critical to building resilience is not just adapting to cope with the shocks and stresses as an endpoint, but really confronting the upstream choices and decisions that we make that weaken resilience and drive our system towards disease, drive our systems towards ecological disruption that increase the risk of emergence of novel pathogens. So in that context, we really need to think about building resilient systems for health, as a play on health systems, that would be looking at how we strengthen our societal systems, our ability to actually prevent the preventable, and in addition to adapting to the unforeseeable. And the fourth point is thinking about integrated governance. So having thought about all of these different components, it's a cross-societal issue. One of the things that I've seen and emerged from the considerations on the pandemic treaty that are in discussion so far is the importance of thinking about a health in all policies strategy. So how do we consider the fact that this pandemic is not a health issue. We've seen this. It's not just ministers of health that got together to say this is a health issue. It's an economic issue. It's a transport issue. It's a jobs issue. It's really a cross-societal issue. And in order to think about creating environments that are suitable for disease prevention, we have to take an integrated approach, right? Recognizing that health just doesn't trickle down from good intentions, that we have to be deliberate about creating health across all facets of society. And the way I like to remember that is thinking about integrated governance as 3 A's, thinking about the actors, thinking about the agency, and thinking about the accountability. So who are the actors that we're talking about that need to be involved? We're thinking about the environment. It can't just be the health sector, right? So who is shaping the natural environments? Who is shaping the built environment? What agencies do they have to act, and what mandates do they have? And who has been held accountable for population health and equity? So bringing this all together, just to round off, I would say that in order to tackle and create and design environments that are conducive and promote disease prevention in an equitable way, we need to think about health from a cost and expenditure to health as investment. We need to have this level of integrated governance that it prioritizes prevention. And critically, we need to move from thinking about siloed health to a more planetary health, right? Because we have this interlinkages between the health and our environment, but we still manage and treat them as in these silos. So how do we rethink and how do we reform the governance for health? How do we rethink, if, in the context of that, how would you define a health system, right? Suddenly, it's not just the healthcare sector. So what is, and I focus, most of my work is on cities. What is the role of urban planning as a critical health system actor? What is the role of transport or mobility as a health system actor? How do we define health infrastructure? Right. So how do we ensure that we're holding accountable the different actors in these different sectors for the equitable and inclusive creation of health, and not just talking about prevention in the context of prevention services in the healthcare sector, knowing that a lot of the ways that we shape our environments are largely responsible for the preventable ill health. So I really think, just to end with that, and end with the money side of things, and we then think about in financing health, we also have to relook at our financing institutions and our financing systems. So how do we incentivize investing in systems for health? We had an opportunity in terms of the economic stimulus interventions that we put post-COVID. Could they have been preconditions on deliberate and measurable strategies to incorporate the impact on health and environment as performance indicators, both in the public and private sector? Could we have seen health as a primary performance indicator of urban infrastructure development? Could there be incentives, economic incentives that aligned with disease burden as attributable to the relevant sector, whether that's manufacturing, trade, or transport? I really think this is the kind of conversation that we need to have, and I think this is the critical opportunity we have to rethink that, because otherwise we're going back to business as usual, and I think that would be a really missed opportunity. So how to design physical environments to better suit prevention? Well, everyone has a health portfolio, and in fact, just to end off, we recently published a Lancet commission on Nigeria. So a Lancet Nigeria commission investing in the future of the health of the nation, and one of our first recommendations was around thinking about creating this governance for planetary health across government, to think about actually creating and addressing the ill health as part of addressing the ecological vulnerabilities that a country like Nigeria faces. So there are some really interesting and exciting opportunities there, but we really have to be bold in looking at our societal systems and be ready to make structural changes.
Thanks, Talula. The little word you dropped in more frequently at the end of what you just said there, how, is a critical one. And I'd like to ask you more about that if we have a little bit more time later on, because of course public health people are very good at calling for equity. They're very good at calling for health in all policies, and indeed One Health. They're much less good at actually telling you precisely how they're going to do that. Health in all policies, for example, emanated from the medical community. One Health emanated from the veterinary community, and they still don't talk to each other, but they're basically saying the same thing. So we've got some real practical problems in implementing these things, but thanks very much for that. So
I'll tell you how, don't worry, Chris.
Okay. Let's see if we can squeeze it in before the end. So actually, I think there are a lot of good examples in urban health, but let's come back to that if we can. So Wolfgang, thanks very much for your patience in waiting. Last but certainly not least, thanks very much. Over to you.
Thanks a lot, Chris. No, it was extremely interesting so far to listen to all of these presentations. I will focus a little bit more here on what we're doing at the European level and give some thoughts in which direction we try to work towards improving preparedness for future challenges for future epidemics or pandemics, thanks to the activities we've been launching. So one point I want to make is that we really believe in the need for a close relation between policymakers, academia, and industry to ensure a proper level of preparedness for future epidemics. There is no doubt about it if we talk about designing evidence-based interventions in the field of pandemic preparedness and response. It sounds a little bit theoretical and also a little bit old-fashioned, but at the end of the day, if we look at SARS-CoV-2 now, the current pandemic, we have seen that at the end of the day, it was an effort of industry, academia, government agencies. We had the regulatory bodies, we had many NGOs, and that cooperation, that concerted effort resulted at the end of the day in a number of very good and very effective vaccines and the number of very good antiviral therapies. And that, to a certain extent, has saved us and brings us back also to the situation that we have here, a post-COVID summit, which is an intermediate step in the reflection on it. But we should not forget that obviously all of the availability of vaccines or antivirals or other therapies that is based on a very long period of massive public and private sector investments in science and technology, including vaccine technology, and by that we were lucky to end up with a couple of vaccine candidates after only a couple of months. The same for some antibody drugs or small molecule drugs for COVID-19, which were relatively quickly developed, and that showed the effectiveness of cooperation, but also the flexibility of the crucial players, be it at the academic level, at universities, or at the industrial level. But nevertheless, we are still in the COVID pandemic, and we still face the next autumn and winter season. And depending on what happens, it might be difficult to handle here again. However, what we have seen is that this pandemic, a bit more unlike former pandemics or epidemics that we have seen, just to talk about SARS, about influenza 10 years ago, Zika, and so on and so forth. Now we really have a strong political momentum here to strengthen health initiatives at national levels, at the European level, but also at global level, and some of the speakers already referred to that. At the EU, we have been reinforcing, we try to reinforce the EU's resilience to what we call cross-border health threats over the past couple of months through policy initiatives. And we have been proposing a quite complete framework for a stronger European Health Union, as we call it. HERA, the Health Emergency Response, Preparedness and Response Authority, is one of the tangible building blocks of this initiative. It was launched last year in October, and we try to get it operational. It is what we call an end-to-end solution that has basically a simple goal, and that is to better anticipate cross-border health threats and enhance preparedness planning that would then lead to a swifter and more effective response at all levels. In particular, looking at ensuring that appropriate medical countermeasures are available at scale and not just at a level that would not help in the future. We all know that, and we heard, it's not the last public health emergency we are facing. We need appropriate tools for future potential pandemics and epidemics, and that requires not just efforts in all sectors, as we've heard it. It requires a lot of funding, and it requires also decision-making power, and that is an important point here when it comes to the implementation of the whatever kind of lessons we learned from this pandemic and from the former pandemics. So for HERA, a physical environment that is better suited to disease prevention would definitely mean timely and at scale availability of medical countermeasures. Might it be from simple things like masks or syringes to more complex treatment options. But it's not just supply reserves and diversified supply chains which are critical. There's many more elements. If we look across the different sectors, healthcare sectors, and other critical sectors, we need to prepare for the unexpected. That sounds also a little bit oversimplified, but that's what it is, and some of the speakers refer to that. We all know that vaccines, as well as now some of the repurposed treatments, for example, are great tools, but again, we need more investments for higher level of pandemic resilience. We need plans, we need initiatives, we need good programs that ensure also the development of further future-prone critical medical countermeasures for public health. And we also need to ensure truly equitable access to such products. So that implies also that modern ways of funding of pandemic preparedness is essential. One element we are looking into is a stronger R&D of diagnostics, but at the same time, we also need to make sure that we maintain or we are able to research the great infrastructure and well-trained staff we have also as a result from the current COVID pandemic. And it does not just refer to the diagnostic sector, but also to the other sectors. There's a couple of examples. So these are just a couple of examples of the lessons that we have learned, and perhaps even some of the structural changes that were introduced over the past 2 years. At HERA, we are, as I mentioned already, HERA is an end-to-end solution. So we start from a threat assessment, from intelligence gathering and threat assessment down basically to the deployment of appropriate medical countermeasures. We are currently conducting a prioritization exercise by establishing regular analysis of scientific evidence on high impact health threats. At HERA, we are not just let's say policymakers. We also have people here with all kind of relevant backgrounds in the medical sector. From we have good scientists, but we also have lawyers, and we have people that are good at policymaking. But nevertheless, as part of this threat analysis, we want to establish, and that's one of the intermediate goals, a list of critical medical countermeasures. It could be vaccines, therapeutics, diagnostic, protective, or other equipments, and that would be able to respond to main threats that would be identified. We are also setting up, as another example, a so-called EU FAB, which is a network of reserved surge manufacturing capacities for vaccine and therapeutics in the EU. Another element with a clear added value, was also mentioned already a couple of times, is obviously the intensified and state-of-the-art use of e-health and telemedicine for pandemic management. Digital tools and remote healthcare services have been proven beneficial during the pandemic, but the potential, at least in some areas or in some regions, still remain quite untapped. So we simply have to make sure that we move on into an era that really makes full advantage of technological applications in health, and that would become more prevalent operational components, not only for regular care environments, but also in the case of health emergency. As a final point, and then I come to the end, I would just like to add to this big picture that for our ideal environment, we should also not forget about data, particularly for risk assessment prevention. So the standardization, the interlinkage of data could massively facilitate dissemination of improved understanding, not just of the viruses or threats, but also for the design of effective interventions at time. And then in this regard, just to mention the European health data space, which is one of the priorities of the Commission to promote a better exchange and access to different types of health data, and to support healthcare delivery as well as the secondary use of data. So I truly believe that to foster innovation in preparedness and make it tangible, a meaningful collaboration between policymakers industry, academia, civil society, and in particular the scientific community is needed. COVID-19 has shown that it's possible, even if it was sometimes too late, but nevertheless, we need to keep up with the speed that that science, the advances in science deliver for better preparedness and response to the next pandemic. Thanks.
Thanks very much, Wolfgang. So that was a really terrific set of presentations which covered a vast amount of ground. We have some time for questions. We've got about half an hour left. There are a couple of questions on the Q&A and I'll come to those. And I think I can see how to direct them. And in fact, there are more questions coming in right now. But so I've made a number of comments and you've stimulated many questions in my mind. But let me invite you, each of you or any of you, to raise any questions that have come to you as others have been talking, which can be general questions or directed at other panel members. So anyone who'd like to kick off, either just speak or raise your hand.
If I could ask a question.
Yeah, please, Wolfgang, go ahead.
No, I liked all presentations. They were all very much to the point and really depicting many of the elements that need a stronger position in my eyes in the future. One point that Bob mentioned is that people forget about past pandemics and about the lessons learned from the past pandemics. I mean, that's also a mantra that's coming back all the time. I mean, is there any hope that it's going to be better this time? By when do things need to be fixed, not to lose the momentum again?
Yeah, but there's three words that I say that we don't use enough as in science. That is, I don't know. And those three words I would emphasize, I don't know. But if you ask me if you push and I had to give a guess, it's one of the reasons we made this global virus network, because hopefully it's long lasting. It's alive and well right now. And if it maintains itself, we feel that we have a duty not to let anybody forget that there will be enough virologists, but we can't, obviously, I think very obviously, self-evidently, we can't do this alone. So I think we need the private organizations that are related and closely related to medical science and funding agencies to be there alongside. So I think private organizations closely connected with academic communities need to make noise about it. And we need the help of science writers very much, so that when things are stabilized, they don't go away and only report on what's the sexiest thing in the world at the moment. So it's my feeling that we have a strong duty to be sure of that, and that's one of the main purposes of the Global Virus Network. But will we succeed? Seeing it up front where we did forget after it seems to be always about a generation and a half or so. It's not in a year or two after it's over. But after the next generation comes along and you're not used to saying anything about, look, I've heard public health commentators that means, I hope not any of the panelists, I doubt it very much, but they were, when listing the pandemics, and then they saw me in the audience and said, oh, sorry, they forgot AIDS. I mean, they don't even bother listing it anymore because we have some therapy for it, as you know, and people can live a reasonably normal, but not completely normal lifespan. And there's nonsense about cure. I mean, no one's really been proven cured, even though we keep talking about the one patient. And there's still 38 million people infected with HIV, but it's not even, they didn't even list it. And I've heard that more than once by commentators. Because we think of pandemics and epidemics as acute viruses, there's no way anybody here in the panel, I dare anyone, to think of how you could have prepared for AIDS. We can prepare for acute virus infections and predict what's most likely and be prepared for this, that, or the other, but you certainly couldn't be prepared for HIV. There's no way, because although the ideas that were out there for the cause of AIDS, yeah, we put forward retroviruses in '82, but there were none. You got all these infections that a person with HIV has. Which one's the cause? The answer was none of them. It was something much more mysterious and harder to find. So you couldn't prepare for that. But going back to your question, I just think we need organizations and connections and partners in industry, et cetera, to have reminders going out, to publish reviews, to publish the past, to point out the little local epidemics that could go further. You hate to do things to scare people. It's not honest. But it seems like the only time they respond is that. So I don't have a good answer, Wolfgang, and I apologize for that. But I have to really say I don't know. I hope so. I hope by these approaches with private organizations and getting more aggressive that we will be sure not to forget.
I think if I could ask perhaps others to expand on what you said, Bob, because the global health architecture at the moment defines a health emergency with respect to the international health regulations. So COVID is a public health emergency of international concern. Ebola was, polio was, you mentioned polio, Bob, and it still is. In fact, it's the longest public health emergency. Zika virus was, but it was John that mentioned tobacco smoking, and we might add to that diabetes, we might add to that obesity. I spent years trying to fight for tuberculosis alongside HIV and indeed malaria. We don't currently have the international health architecture to deal with chronic diseases or something that's not, in your words, Bob, an acute respiratory virus, essentially, which will provoke a health emergency. I mean, Ebola was as well, Zika was as well, but those kinds of infections. So I'm interested to hear others' thoughts on that. How should we think about, how could we make some significant changes to the way we think about health emergencies, and how could we put that into practice? Wolfgang, I'm sure you've thought about it with respect to the EU, which is a major decision-making body. Those were the words that you used, but others will have some thoughts as well. Talal.
Yes, I just wanted to build on Bob's point there, because I didn't mention in my intro, but for a while as well, I was focused on HIV and TB in my research, and Bob, whilst I agree with you in terms of preparedness for at an individual and even localized level, and for HIV, I think one of the key lessons that we don't seem to have learned is that we could have prepared in terms of preventing millions of deaths by making antiretroviral therapy accessible globally much earlier, and we could have saved millions of lives.
And if you succeeded in having Mr. Mbeki stop saying that HIV didn't exist or it didn't cause AIDS,
right,
you would have saved a lot of lives in South Africa.
Right,
so,
but
yeah.
but it was related to that, but it was also related to the cost of and access. It relates to the rest of that,
yeah.
and that is playing out. So all of these, there's the pharmaceutical, there is also the political, and we are seeing that playing out now. Again, with the COVID vaccine equity globally and access to that. So in a sense, this is a new virus, and I'm not a virologist, so excuse any ignorant words that come after this, but we don't yet know what the impacts of having having this level of virus and this levels of low levels of vaccination in significant parts of the world would be on the evolution of the virus, on the long-term consequences, on the chronicity, etc. And so it is frustrating. And then speaking to Chris's point in terms of the global health architecture, we still are not able to ensure access, having developed a medical product at a record time. We're still unable to get through those barriers, and we're still seeing this similar barriers to access globally. And so I think there's some aspects that we can prevent and we can prepare for, but we aren't.
Yeah.
On the
yeah. Once you know the cause and have it in hand, yes.
On the political processes, which in my view are critical, you'll remember, Bob, that one of the most significant international events, as far as HIV was concerned, was the United Nations General Assembly on HIV/AIDS. Though health is very rarely discussed at summit level, in other words, heads of state level. So getting it on the agenda at UNGA is crucial. And I think probably the AIDS summit was probably the most successful in terms of health. But recently, and this is a question perhaps for Paul to consider, recently antimicrobial resistance was also on the UNGA agenda. And it flickered briefly as being high profile, but has since subsided a little since then. And I'd be interested to hear from you, Paul, because you mentioned antimicrobial resistance several times. I'd be interested to hear your views on where you think that now stands.
Yeah,
in terms of public perception of the importance.
Yeah, absolutely. But first, I would like to address the comment that Talal made. Because Pfizer and BioNTech have committed to provide 2 billion doses over 2021 and 2022 of the vaccine to disadvantaged populations around the world. And so we've already provided 1.3 billion doses as part of that commitment. And also for the drug for COVID-19, we have already 36 countries that will be able to manufacture, low and middle income countries that will be able to manufacture our drug under an arrangement with the medicines patent pool. So there are significant efforts to provide relief in that regard. In terms of AMR, I do think AMR looks a lot like climate change, in that it is something that is slowly creeping up on us. Now and then it gets some press and it gets some form of recognition as an issue that needs to be addressed, but it's far from enough today. And what was published in the McNeil report, for instance, if we continue the way we are, by 2050, we'll have more deaths due to resistant infections than due to cancer. And so there's a lot more that needs to be done. And I think the surveillance that we're doing helps in recognizing the size of the problem and where the problem is important. But we do need to do a lot more in order to address antimicrobial resistance, but policy, facilitating new drug development, and also stewardship to ensure that the existing antibiotics are used appropriately in the right patient and at the right dose and for the right indication and so on. So I think a lot more needs to be done in terms of awareness of antimicrobial resistance and the measures that need to be taken in order to combat it. And COVID-19 actually, I think, has recentered the focus on the importance of infectious disease, and hopefully will also help with efforts to combat antimicrobial resistance. They're very similar, actually, right? So they spread quite fast, actually. There's tremendous human and also economic impact, and they really need a concerted effort across many different stakeholders in order to address them.
Yeah, thanks, Paul.
Chris, can I jump in here for a moment?
Yes, please.
I think the issue of intergenerational loss of the importance of something like an infectious disease threat is something that we're going to have to continue to grapple with. And I think it was very evident from the fact that how poorly politicians were able to respond to this almost unilaterally. And the reason is that this is something that is infectious diseases is a threat that's very low on their list of priorities. It's something they don't think about. And it's rare that you have an event that takes place that brings it up so that it is the #1 priority to have to deal with. You know, sociologists apparently talk about the 3 S's in a bit of a tongue-in-cheek way. They say for an event to be really considered and for people to invest in it and want to actually keep it in focus, it has to be soon, salient, and certain. And when you look at something like this pandemic and acute infectious diseases, or AMRO, they're not checking all three of those boxes. I mean, there are other problems like climate change that check none of them, that have a real problem because they're neither soon, certain, or salient. But in the instance of this, we're dealing with something where the funding priorities are going to shift in the coming decades if we don't have an acute threat again. And we can have seen it with HIV, we may see it with AMRO, we certainly could have seen it in the past. The United States was very poorly equipped to deal with it because we hadn't had an infectious disease threat that materialized for the entirety of the population, HIV notwithstanding, because it really didn't. Many people went about their lives without considering it since 1918, and nobody was alive since that time. That makes it very difficult to contend with. It's not like sanitation or clean water. It's not something that the continual investment in every year is needed to make sure people stay safe, and where the infrastructure can be built out to help with 1 in 50-year events and buffer against those. So we're going to have to be pretty clever to think about how to make this something more immediate to people if we're going to retain their attention over years. And that goes also to reducing inequities, because the first people who are going to get left by and by are the disadvantaged, are the community of color, and the neglect in the process.
Yeah, absolutely. Well, the argument about soon, let's say the word soon, is the argument used by the co-benefit community. So if we want to think about climate change, then also emphasize its role linked to air pollution, which is killing 8 or 9 million people a year right now. So by relieving air pollution and contributing to the mitigation of climate change, you can save many million lives immediately. But those arguments are out there, they're having some effect, but they're not gaining the kind of traction that an acute event has that kills a lot of people with a great deal of uncertainty very quickly. And so that's the sort of environment that we have to sort of mimic if we're going to encourage greater investment. Let me just turn to some of the questions that we've had online. The first of them, I think, is an important one, actually, and it was touched on by you, Paul, at the beginning, but anyone should feel free to offer an answer. It is, how far can we push health data collection in terms of privacy? And of course, I think what this is getting at is that there are always two sides to the coin. Data sharing is what science commonly calls for, but with data sharing comes a risk in terms of privacy. At least that's often the way in which it's perceived. Others will say, if you can guarantee privacy, then that is the basis for good data sharing. But I'd be interested to hear from any of you, but perhaps starting with Paul, what your response to that is.
Yeah, of course, data privacy and personal health data privacy especially is very important. And so when we gather data, we of course ensure that the data is de-identified, especially when we share data, of course, as well. And there are measures in place and there's techniques in place to do this reliably. So as long as the data gathering and sharing is done within those parameters, I think we should be fine.
All right, thanks. Let me turn to the second question, and perhaps this is one for Andy or Jeff. Both of you spoke about modeling data, and John, you spoke as well. So the question is, regarding SARS-CoV-2 modeling, how can we factor in new emerging variants becoming predominant faster and faster? And I guess this is referring to the idea that, well, currently we have Omicron and we have sub-Omicron in various forms. It's highly transmissible, more transmissible than the original variants of SARS-CoV-2. How do we deal with that in terms of modeling? Andy, Jeff?
Well, in mathematical models, it's a question you want to tackle head on. So very often people come at modeling naively and they think that you just built a system and then you run it and then you have a result. The greater state of the art at this point is to build a mathematical model and to couple it with data through some sort of inference. This can be a frequentist approach. It can be a Bayesian approach. The details are highly varied in how you want to do it. And the aim is to try to fit the model to the observations you have at hand in order to infer the underlying properties that are represented in the model. How rapidly a virus transmits, what fraction of the population is susceptible to that virus right now. Some people stop at that point, and that is actually a recurrent flaw in the field right now that really needs to be remedied, because you have to take it beyond that and address the identifiability of the system. And that is the ability of the system to find the true solution, given the structure of the model you have built and the richness of the data that you have at hand, reliably. Can it actually make those inferences appropriately? If it can, that provides you a system that can be the basis for inference, for forecasting, for projections, for counterfactual simulation in a way that is more robustly anchored. If you build a system like that, and I'd say a small minority of models do that at this point, you can infer the properties, including the changing properties. That would be the change in transmissibility. How much more transmissible is Omicron than Delta when it emerges in South Africa? What fraction of the population that had been immune to infection from Delta because of vaccination or prior infection with that variant is now susceptible to infection by Omicron? In other words, what's the immune escape of it? Now, like anything, you don't want to just run the model in and of itself and trust that wholly. You want virological approaches, you want microneutralizing assays to be run in the laboratory, and you want those comparatives to align to provide a whole balance of data that you can look at to really understand where different vantages are coming at this problem and what their solutions are to it. But the idea is really to be agnostic about it, to build good systems that are identifiable, and to find the solutions that are there and address those very questions that this person asked about.
Yeah, I think perhaps the larger question behind this is, how do we deal with modeling and forecasting when we can expect the unexpected, the uncertainty? Before Omicron, we never knew or imagined that a variant was going to arise with so many different mutations simultaneously. Nobody conceived of that, or that the consequence of that would be a great a high degree of transmissibility. So I was amazed, actually, Jeff, by your projections for Salt Lake City. That was a remarkable piece of forecasting. But had Omicron reared its head somewhere along your forecasting curve, then I guess your forecast would have been a lot less successful. And the question is, how do you deal with the uncertainty?
You're absolutely right. And that's the difference between a projection and a forecast, I would argue. If the system is stationary, like seasonal flu is, relatively speaking, you can generate forecasts that are going to be statistically calibrated. They're going to have sharpness, accuracy, reliability, all the things that are used in forecasting science for almost 100 years.
But
for COVID, that's not the case, Chris. The problem is exactly what you say. The system is not stationary. Our control of the system is varied through time, and these variants are emerging at any particular time, and we don't know. Omicron was the most extreme example of it. And to say we didn't anticipate it, I would push back on a little bit, because whenever I was asked at the press in September of 2021, what's going to happen in the winter, one of the three things I said is there could be a variant that emerges. We don't know what's going to happen. That could change everything. And it unfortunately did. Once the variant emerges, we can tell you about its properties and say what we think it will do. But in the case of COVID, this is really if-then statements. If society does this and no new variants emerge and we have the same properties, this is what might happen with this level of uncertainty. That's the best you can do with COVID, and that's the best we've been able to do since it emerged.
Yeah, a politician might say, might ask you, well, how can we be cautious in the event that we don't know what's going to happen without spending too much money in being excessively cautious? However, let me move to the third question very briefly. And I think, John, this is probably one for you, and I'll abbreviate it. It says, where is the role of scientific evidence for medical treatments as a basis for health policy in the face of the emergency situation of a pandemic? And I guess what this is getting at, if I've not misunderstood, is that we want the scientific evidence. We want to do the randomized controlled trials, as you've said, but we're in an emergency, and we can't always get the information that we want in an emergency. And the example in this cited here is the 4th dose of COVID vaccine and the evidence base for that, as it were. But I think the general question is, how do we manage in an emergency to get the standard of evidence that we'd really like to work with? Just a brief comment for you.
That's a very important question. And I think that, of course, if we know nothing, then we go with the precautionary principle, and we try to get a response that is both prompt and likely to have the best outcomes if we consider, again, all these multiple dimensions that I mentioned during my presentation. But this doesn't mean that we should just abandon the effort to get better evidence, and that includes randomized evidence. I think a major lesson from the pandemic is that we can get randomized evidence very quickly. I think that the major success for me was the ability to launch these wonderful adaptive trials like Solidarity and Recovery, and get very conclusive results within just a few months. And of course, emergency is an emergency, but we are in an emergency for over 2 years now, and we can get answers with large randomized trials on important treatment questions within just a couple of months. Vaccine trials, they gave us answers within probably even less than that. And I would argue that we need more of them. So, downstream, when we're talking about fourth dose, or, downstream probably fifth or 10th dose, I think we can do, and we should do, randomized trials. It's wonderful to have observational data. We're not going to discard those. They will tell us a lot. I recently published a paper in BMJ, ABM, trying to look at the factors that may affect estimates of effectiveness for vaccines, for example, in an observational setting. But this doesn't really get us off the hook for the need to do randomized trials. And if we don't have the results within the first few months, we will have them after a few months. That can happen both for medical treatments and for social distancing and non-pharmacological measures. I think that I mentioned the mass trials, which I think were very useful. There's a number of other trials that have tried to do this. Very, very little investment, though, has gone in that direction. And it's very unfortunate that we have so many gaps in our knowledge in the moment. I mean, if we're hit by a new variant that is far worse than Omicron, we will be back to square zero for many of these decisions, which is very sad.
Yeah, that's a great answer, John. Thanks very much. I mean, I think, in short, you made the point that even if we're in an emergency, we don't really have to lower the standard for collecting evidence. And we've seen some amazing results from trials, Recovery and Solidarity, you mentioned, and they really have done extraordinary things and led to the saving of many, many lives because of the treatments that they've shown to be effective. We just got just a few minutes left, and as I said right at the beginning, what I'd like from each of you is just half a minute or 45 seconds on your final thoughts on what's been said, what you've heard, and I'll just go around the screen. So Andy, you're first on my screen.
Thanks. Yeah, I guess the common threads I picked out that are going through what everyone said is that these inequalities, inequities, lack of cross-government global collaboration, and lack of consideration of the wider situation. So, and I think there are, as Jeffrey said, we are now in this situation of a government's funding, paying attention, soon, certain, and salient situation, and we can, I think, as Tallulah as well highlighted really well, that there are things we can do that are common, that are the basic health systems, that are improving access, that are things that we know should help in the future. Although there's a huge amount of uncertainty, there are these inequities in data, in surveillance that mean we're flying blind in some parts of the world in terms of new variants arising. So there are things we can take advantage of these eyes looking on the situation now. So
thanks, Andy. Paul, over to you.
Yeah. Thanks. What I've learned from this discussion is, first of all, how important it is to have everybody involved in preparing for the next pandemic, because we've got very different points of view from the very scientific all the way to more social aspects and equity aspects, of course, as well throughout. And I think it's very important to have everybody around the table and to, in a systematic way, prepare for the next pandemic, while, as some of you said, the memories are still fresh. And so I think that's what I take away from this panel. One aspect that we've just touched on peripherally, but I think is very important also, is communication. I think part of pandemic preparedness really needs to touch on communication and and how we address head-on potential misinformation or preventively potential misinformation, and how we enhance trust in the institutions that provide information.
Yeah, thanks, Paul. Comms important, and perhaps we spent too little of time on that. Bob, your final thought?
Notes, because he gave a total summary of the meeting, and I think Paul made very good points, and to fill it in, there's nothing useful I could add to what has been said.
Okay, thanks, Bob.
Thank you.
Wolfgang?
Thanks a lot. I think one of the points I take from this discussion is that we should not forget about the good elements. So things that have improved throughout the pandemic, and that were not a consequence of the lessons learned of the past pandemic. So that should be kept for future pandemic preparedness planning. Second point is that the implementation is obviously the key point. It comes with funding needs, and huge funding needs. So that's also a positive element that should be kept on being invested. And then the third point is that it's not just about plans or ways of implementing it, but it's also about good and smart decision making, so that the tools are there and that the right people are at the right positions to take decisions during preparedness times, but also during the crisis times. That's what I take from this discussion.
Thanks very much, Wolfgang. Very, very useful. Jeff?
Sure. Thanks for inviting me here again as well. Yeah, I think I'm going to echo the communication point. I think it's very important that we establish the means for communication, and that also means having the channels where individuals and governments can find the correct scientific knowledge for the moment. It may, in the next pandemic, be none of us here, hopefully, because we'll all be dead before that happens. But it may be that our expertise doesn't align with it anymore, and we have to find the right people who really have the right expertise for that moment to be the ones communicating, and not just the usual pundits spouting dogma and narrative. And I think the dogma and narrative is something that we also have to look at inwardly. And it goes to Bob's point about the issues associated with aerosols, asymptomatic transmission. We could say it about the early communications about wearing face masks. They were very confused, and they were very embedded in just sort of this dogmatic narratives that really weren't evidence-based. And we needed people to peel back and say, we don't have evidence. We haven't studied this virus. We don't know if it's transmitted by droplet or aerosol. So that level of honesty also needs to be retained.
Great points. Talula?
Thanks. Really great points. I have three quick things to add. The first is around the seeing early learning and early listening as a critical part of emergency preparedness. So history came up a couple of times, but also learning from other people and other countries and other contexts. The second is that working in terms of prevention requires everybody to be working towards prevention. So this is aligning our societal and economic and all our systems for actually prevention of ill health. And the third, really, again, because it's so important, building on the communications thing, seeing building of trust as a journey. So sustained and not just in emergencies. It's very difficult to build trust in the middle of an emergency. And critical to that is tackling the inclusiveness of science, because the representative matters and the messenger matters. So we can see working proactively to ensure better representativeness in the scientific body as a critical part of emergency preparedness.
Thanks, Talula. John, you get the last word.
Thank you for asking me to be part of the panel. I think I learned a lot, and lots of great insights were generated. I think that a pandemic is entirely uncertain when and how and where it would hit next. So we need to be prepared, but preparedness should not really disrupt our lives. We should try to seek win-win situations where we very silently but very steadily and committedly invest in solving big problems that would create a bigger problem in case we get a pandemic. So we have so many chronic and not just chronic health problems that are brewing. We mentioned a number of them in our discussion. And I think if we work on them, and also if we work around some very deep inequalities and inequities within our societies, we would be prepared for any crisis, or at least better prepared. So I think that hopefully the pandemic is leaving us, but we need to work on all these things that made it worse.
Thanks. Thanks a lot, John, for that last word. And thanks to everybody else for joining in. This has really been a fantastic discussion. I've learned an enormous amount from it. And when it comes to the powers that be considering risk assessment and prevention for the next pandemic, I think you all need to be together in the room, and I hope that happens. But thanks again. I've enjoyed this. It's been fantastic, and enjoy the rest of your day. Thanks very much.
Thank you.
Bye-bye.
I was going to add, let's make sure that Putin's epidemic doesn't become pandemic.